patients with renal impairment, now compared to those without kidney impairment, who receive anticoagulants appear to be at increased risk of bleeding based on recent clinical trials. So how can we reduce this risk for patients who are optimally managed with anticoagulant therapy? We have some answers perhaps. Incidence and characteristics of major bleeding among rivaroxaban users with renal disease and non-valvular atrial fibrillation. That's the title. I'm with Dr. W. Frank Peacock, who is an MD and professor of emergency medicine at Baylor College of Medicine in Houston and the associate chief of emergency medicine research there. First, before we get into this particular study, why did you do it?
Well, I think you brought that up when you started, is that the perception is that people with renal disease suffer greater risk of bleeding than people without renal disease when they're treated with anticoagulants. And so we wanted to find out, is that true? And that data is from the warfarin era, and those people have all sorts of bleeding trouble. I'm an emergency doctor. We see this as a routine problem. So this became an important patient management question.
Now, in this case, you're evaluating a group of patients. Tell me about them and what you did to analyze the data.
Yeah, so these are non-valvular AFib, so people who clearly need to be anticoagulated. Right. And we were able to access it's a Department of Defense data, and we've been following this for a bit of time in a post-marketing surveillance study. And so we're able to take large chunks of patients and find out what it looks like in the real world, because when you do a study, you use really defined, sharply controlled populations. When you do real-world data, it's a mess, because people have, in a study, they'll have one disease and they'll get treatment, the perfect treatment, and it'll be perfectly regulated. In the real world, people go out for a beer and they skip a dose and they do all those things that people do.
Yeah.
So that's what we looked at, is those two populations. And we found it's really, I found this to be quite surprising. The patients with renal failure bled at about exactly the same rate as the patients without. So the bleeding risk was 0.09 per 100 patient years. For the 36,000 patients who did not have renal disease, we had about 7,000 patients with renal disease, and the bleeding risk was the same in both of them. When you looked at what the bleeding was, the bleeding risk in patients with renal failure for intracranial hemorrhage was actually lower numerically than it was in the patients without renal failure, which is really reassuring, because the intracranial hemorrhage is what is associated with fatality. It's about a 50% mortality rate if you show up in the ER with an intracranial hemorrhage. Like the other trials that have been done, there was more GI bleeding and there's an increase in the risk of GI bleeding, but the risk of death goes down, actually. So it was comforting to see that. And the way I would spin that is this sort of nuisance bleeding with the GI bleeding, but the important stuff, the mortality stuff, is low.
In terms of, are we answering the question now to the point where, if the perception has always been that these people are at greater risk, do you think we've now shown that with this data that's really not true? Or do we need to do more studies to determine whether or not what you found is indeed correct?
Well, we're looking at 40-some thousand patients. Exactly. I feel pretty comfortable to say that this is probably the real world. Expectation is about 7.7% of the patients are going to have a bleed. We do know that patients, and the way it worked out here is the patients who had renal failure and a bleed, their CHAD scores were over 5. Those are the people with the greatest risk of having stroke. So you have to make this risk-benefit assessment, and the risk for these people is huge. So you get to choose. You get to have a stroke, and a 5 CHAD score is a lot of strokes, or you get to have a bleed in about 7.7%. It's really easy for me, since the risk of death is low and the risk of stroke is awful. I would rather bleed, have a GI bleed, than to have a stroke, because I'll get over my GI bleed statistically almost all the time. Whereas with a stroke, you are in a nursing home wearing diapers.
You still look at the data, though, and you see there are a lot of people who are high risk who are not on NOACs or any kind of anticoagulation. There are a lot of people who don't qualify who are at low risk who are on. How can we get this corrected? Yeah,
so we're transitioning from what I call the ugly drug era, the warfarin era, which, in the ER, people would come in with intracranial hemorrhages on warfarin, and they were awful. And so we're transitioning from an era where we have a difficult drug. You've got to have levels measured, you can't eat certain foods, you can't drink, all the things that people like to do, and screw it up. So even in the good trials, warfarin works about 2/3 of the time. And we know that when you move it to the real world, you don't get the good trial rate. So here's a drug that doesn't work, it's a pain in the rear. So patients don't want to be on it forever. It's a challenge. And now we're moving to a whole class of drugs where it's easier to take and it actually works. And so we're having to recalibrate how we think about anticoagulation. The risk of bleeding is real. I mean, you know, it's called an anticoagulant, and it works. Otherwise, it wouldn't work. So you do have a risk of bleeding. That's just the reality of it. But it's small, and the risk of death associated with it is very small.
Oh, terrific. I thank you very much for this. And we have a lot of coverage from the American Heart Association meeting, which is online and also will be in 2 cover stories for CardioSource World News, where I'm Executive Editor Rick McGuire.